This lecture is intended for undergraduate students, and today's topic of discussion is muscular dystrophies. The term dystrophy means abnormal growth, and muscle dystrophy is distinguished from other neuromuscular disorders by four main obligatory criteria. It is primarily a muscular disease, it has a genetic basis, the course of this disease is progressive, and degenerative and death of muscle fibers occur at some stage in the disease. So if we have these four criteria, then we can say that this is a muscular dystrophy. Then there are types like Duchenne and Becker muscular dystrophies, Emery-Dreifuss muscular dystrophy, myotonic muscular dystrophy, limb-girdle muscular dystrophy, facioscapulohumeral dystrophy, and congenital muscular dystrophies. This is a pictorial presentation of different types of dystrophies, and the common feature in all of these is that proximal muscles are involved. Let's start with Duchenne muscular dystrophy, and then we will discuss how we can differentiate Duchenne muscular dystrophy from other kind of dystrophies, what makes it unique. So the Duchenne muscular dystrophy is the most common hereditary neuromuscular disease in all races. The incidence is about 1 in 3,600 live-born infant boys, which means that this disease is present exclusively in the boys. The cardinal clinical features are progressive muscle weakness, intellectual impairment, hypertrophy of calf muscles, and proliferation of connective tissue in muscles. This disease is X-linked recessive. This disorder is caused by a mutation in dystrophin gene, which translates for a protein named dystrophin. Without dystrophin, the muscles are susceptible to mechanical injury and undergo repeated cycles of necrosis and regeneration. So what happens is that ultimately, because of repeated cycles of mechanical injury and regeneration, these capabilities are lost, and the muscles, they start to fatigue, they start to die and replaced by fibrous tissue. The cardinal feature of Duchenne muscular dystrophy is muscular weakness, which usually starts between the age of 2 and 3 years of age. Although histological and laboratory evidence of myopathy may be observed from birth in some children, but it manifests itself clinically between 2 and 3 years of age. This is an example of calf muscle hypertrophy. This is pictorial presentation of progression of disease, that here the child is almost normal, and as he has grown, his calf muscles have hypertrophied, and there are postural changes like kyphoscoliosis. Clinical features are divided into different stages, which are presymptomatic, in which the patient has no symptoms. Clinically he is well like normal children, but his CK is raised and he has a positive family history. Stage 2, in which the child starts to become clumsy and waddling gait starts. This usually happens at the age of 2 to 6 years. From this point, the progressive muscle weakness starts. This usually starts in the lower limbs, but later on it also involves the neck flexors, shoulders and arms. At this stage, child is still capable of climbing stairs. Gower sign. This is a classical sign of Duchenne muscular dystrophy, in which child is unable to stand from sitting position and he uses his hands to stand up. Now comes the stage 3, which starts usually at around age of 8 years, and the difficulty in walking has progressed. Now the parents notice that the child cannot climb stairs, and the respiratory muscles begins a slow but steady decline. He cannot arise from the floor. The forced vital capacity begins to gradually wane, leading to symptoms of nocturnal hypoxemia, like lethargy and early morning headaches because of carbon dioxide retention. Early non-ambulatory stage 4, in which child is capable of self-propelling himself. He is able to maintain the posture, but because of asymmetrical weakness of paraspinal muscles, the vertebral column anomalies like scoliosis starts to develop. Late non-ambulatory stage 5, scoliosis has progressed and the child is usually wheelchair bound. If at this stage the child is wheelchair bound and very weak, the patients usually develop terminal respiratory or cardiac failure by the early 15 to 20s, and because of the weakness of his respiratory system and the weakness of gastrointestinal system. His nutritional intake is poor, and at this stage, contracture starts to develop. Complications of this disease include cardiomyopathy, lung failure, decreased self-independence and mobility, mental impairment, and formation of contractures. On physical examination, neck flexors, wrist extensors, quadriceps, tibialis anterior, biceps, and triceps. These are the muscles that are mostly affected. Deep tendon reflexes slowly diminish and ultimately disappear. Pseudohypertrophy of calf muscles develop, as we have seen previously in a picture, and contractures start to develop. Equinovarus deformity of ankle develops, and as I already told you that the paraspinal muscle weakness leads to the asymmetrical development of vertebra, which leads to kyphoscoliosis, which ultimately cause pulmonary and gastrointestinal function problems. So if you have a patient and you suspect a Duchenne muscular dystrophy, workup usually starts with serum creatine phosphokinase, which is elevated. Then nerve conduction studies can be done, which will show a myopathic pattern. Other tests include muscle biopsy and molecular diagnosis. ECG, echocardiogram, and imaging studies can be done for the workup of the complications of this disease. Now, let's see how Duchenne muscular dystrophy is similar and different from other dystrophies. The main differential of Duchenne muscular dystrophy is Becker's muscular dystrophy. It is similar to Duchenne muscular dystrophy in that they both have calf hypertrophy, CPK is raised, and both have X-linked transmission. But Becker's differ from Duchenne that it has a much slower progression. Usually the diagnosis is made later and the symptoms start usually at the age of 6 to 8 years. Spinal muscular atrophy. Spinal muscular atrophy is a disease of anterior horn cells of spinal cord. So this is not truly a muscular dystrophy, but it demonstrates proximal weakness. So it resembles to Duchenne muscular dystrophy in that sense that both have proximal muscle weakness. But it differs from Duchenne muscular dystrophy in a sense that deep tendon reflexes are absent and fasciculations are present. And CPK levels are normal, pseudohypertrophy is not present. Emery-Dreifuss dystrophy. It has almost similar clinical picture to Duchenne muscular dystrophy, but it differs with respect to no calf hypertrophy. CPK levels are normal. There is an early development of elbow and ankle contractures. Limb girdle dystrophy. It is similar to Duchenne in a sense that both have progressive weakness, but it differs that there is no pseudohypertrophy and CPK levels are only mildly elevated. Now the main differential of Duchenne muscular dystrophy is Becker muscular dystrophy. As we have discussed previously, that Duchenne muscular dystrophy has an early onset, usually between 2 to 5 years of age, while Becker dystrophy usually starts between 8 to 10 years. Duchenne is the most common muscular dystrophy, while Becker is less common. It has a rapid progression and subnormal intelligence. The patient of Duchenne muscular dystrophy's life expectancy is 15 to 20 years, while Becker muscular dystrophy patient can live up to their 30s and 40s. Cardiomyopathy is common in Duchenne muscular dystrophy and usually is a cause of death. The patients with Duchenne muscular dystrophy are less ambulatory and are usually wheelchair bound by the age of 10 to 11 years, while Becker muscular dystrophy patients can ambulate up to the age of 20 years. The one very important point, the patient with Duchenne muscular dystrophy has poor prognosis and usually the life expectancy is 15 to 20 years, while Becker muscular dystrophy has more benign course and patients can live up to their 40s or 50s. As these are X-linked recessive diseases, so it is very important to detect the carriers. All the family members of the patient of Duchenne muscular dystrophy should be screened. Earlier, CPK was a test of choice for carrier detection, but it is elevated only in 2/3 of female carriers. But now, If we have a known deletion or duplication of dystrophin gene, testing of carrier status can be performed by testing these possible deletions or duplications. Treatment. Unfortunately, there is no medical treatment available, and the basic purpose of treatment is to improve the quality of life and manage the complications. The most important of which is the preservation of good nutritional status and help to keep the ambulatory status of patient as long as possible. Genetic counseling is a very important part which is unfortunately not done in Pakistan because we do not have genetic counseling experts. In these sessions, we can educate the family about the disease, their prognosis, and the transmission, and we can provide emotional counseling to cope with this stressful disease. There is a one potential treatment that is under investigation that is called exon skipping. As the name shows, that exon skipping is a technique in which we skip the exon that is defective. This skipping is done by masking through a molecular patch the exon that is responsible for production of faulty protein dystrophin. So when this exon is masked, this does not produce faulty dystrophin protein and can cure this disease. Thank you very much.